Thank you. Well, you are always the savior.
How are you?
Doing okay. All right, welcome to the Pediatric Subcommittee meeting. We're getting a little bit of a late start. The last meeting went just a tad over. We've got quite a bit to cover, so we are calling this meeting to order. All right, we begin with our roll call as usual. I'm Charles Macias, Chair of the Pediatric Subcommittee. Brett DeVillier. Here. Justin Hensley, I know is not here. Bonnie Hartstein. Charles Checkwith. Juan Juarez, I know is not going to be joining us. Diana Kraus. Yep. Oh, there you are. Julie Lewis. Here. Jorge Sainz. Here. Sally Snow.
Here.
And Vern Walker. Okay. All right, so we do have a quorum. We will move on to our committee liaison reports. We start with Air Medical. Jorge Sainz.
We'll be meeting this afternoon. There was nothing to report from the previous meeting.
EMS is Vern Walker. We'll get an update at the next meeting. Charles, Education.
Education had an interim meeting, and they looked at the strategic planning and also looked at sorry about that. Usually my big mouth carries good. The Education Committee looked at the strategic plan during their interim meeting in July, and looked more on the community paramedic, and at this time they didn't have anything really to connect to the pediatric committee at this time.
So I think the issue of community paramedicine has come up in several regional and national forums in the pediatric community. Is there intent in that group to address the pediatric scope of paramedicine?
It will be, yes.
Thank you. Injury prevention, Diana?
Yes, injury prevention met in Fort Worth on July 25th, and they're meeting again this afternoon. They completed work on a resource document entitled Hospital-Based Injury Prevention Components. This document was developed to assist hospital-based injury prevention programs to enhance injury prevention program capacity by defining essential core components and providing supporting materials to achieve those core components. This document was made available online for public comment, and it is slated to be discussed this afternoon when they meet again. They've also developed some recommendations for the 2014 State EMS Trauma Strategic Plan.
All right, medical directors is Juan's. We'll get an update at the next meeting. That brings us to stroke. Julie?
The stroke committee will meet today at 2:30. I wasn't able to attend the last meeting, so I don't have a report, but I will have a full report from today's meeting for our next meeting.
Trauma systems. Sally?
Trauma Systems meets tomorrow morning at 10:30, and I will submit a report from that meeting for the minutes.
Okay. Are you aware of any pertinent burning issues for pediatrics we need to discuss today?
No, not that I know of, unless somebody else knows something I don't know.
Okay. RACs, Britt?
I was unable to attend the last meeting. They do meet tomorrow night. I know EMSC has definitely been involved with the RAC chairs, presentations and things, so I will send the information for the minutes.
Okay. And disaster planning, Bonnie.
Hi, yes. So the meeting just occurred prior to this meeting. Some highlights of that meeting were that there was a discussion of the AMBUS project within the state of Texas, which has been successful and is deployed across the state. Of note for pediatric relevance, there's the capacity to evacuate hospitals using isolates. I thought that was, and securing isolates. I didn't catch how many, I don't know how many can fit in an AMBUS, but I thought that was of relevance to our committee. There was a lot of discussion on pre-hospital screening of EMS personnel who may deploy to a disaster setting and what that should look like. Not as much relevance for us. I also can provide an update on the STEER program at this point or later if you'd like.
It's on the agenda as a separate item.
Okay, sure.
Great, thank you. So moving on to our full agenda, we do not have a replacement liaison discussion with child fatality review teams. Hope to have a better liaison link at our next meeting. That moves us to our position paper on minimizing CT radiation, updates on implementation strategies, linkages to EMSC state program. Jorge?
Yeah, we were discussing, you asked me and Juan, Dr. Juarez, to see if, we could come up with a strategy. We thought that the best implementing strategy will have the best impact at the manufacturer level. We're still kind of like debating how we're going to be able to influence the manufacturers as far as, implementing from the get-go their prevention and monitoring for pediatrics. So we're still kind of like a work in progress in that regard. We had the other in the websites. We had submitted to you the previous websites linkages and so forth and so on.
Okay, so we still have the ability to offer rules revision that would at least increase the attentiveness to pediatric dose protocols for 2017 rules revision. So we'll keep that on the agenda for perhaps the winter meeting, not November, but the February meeting. Is that
okay.
Good. Okay. Okay. Pediatric Facility Recognition Program. Sally, did you want to comment on where?
I was just going to say, we yesterday at the EMS for Children Advisory Council, Dr. Kate Remick talked a little bit about where we are from that advisory council perspective. And as everybody probably knows, we did 2 webinars in April, and hopefully you have either seen those or will go and look at them on the EMS for Children website, because there's a lot of really good information about the facility categorization process and what that might look like in Texas. Kate shared with the group yesterday what other states do in terms of those states that have mandatory processes and those that have voluntary. And we also are very lucky to have an emergency medicine, a PDM fellow, Tim Rattan at Dell Children's, that has applied for an ACEP fellowship, and he is going to try to work out a program where ACEP will allow us to use some of their resources to build a database for identifying physician and nurse coordinators for pediatrics in all the hospitals in Texas, and hopefully to give them some resources and to be able to get those coordinator people in positions will help us move forward to hopefully a pediatric facility categorization process in the future. We don't even know yet what that's going to look like, but more to come on that.
Yeah, I think it's important to note that we've really been primarily exploring the voluntary recognition program as opposed to a mandatory program. But with that said, since the next agenda item is our EMS for Children State Partnership update, Sam, could we ask that that be a discussion of the facility recognition program be the first item on that? Do you want to go ahead and give your report?
Good morning. As far as the facility recognition program is concerned, I would actually turf that to Dr. Remick, not to throw you under the bus, but she could probably explain that process a little better since she's been chairing that subcommittee. As far as the rest of the EMS for Children is concerned, we have received the national data just recently on the EMS reassessment. We'll be compiling that data into a presentation that we will give to you while we're looking at February timeline. The other thing is that the EMS recognition program that we've been working on, we do have a draft product for you now available. If you don't remember what that is, just briefly, it is a program that will recognize an EMS agency for things such as carrying the proper pediatric equipment, having current pediatric protocols, doing pediatric continuing education, and providing community outreach for pediatrics, things such as helmet safety checks, car seat installation, that type of thing. I would like to present that program to the Pediatric Committee to obtain your input and comments. I don't know if I can just send that to you via email. And
So if you want to give us a brief description, we can take the document and post that for public review as well and discuss it in our November meeting, but we have an ability to get some public comment today.
Okay.
And then as well as our November committee, and that I think meets all our regulatory compliance for public viewing.
Okay, I can do that. Okay. And otherwise, I'll turn it over to Dr. Remick, and she can discuss the facility recognition program.
So the idea behind pediatric facility recognition comes from a growing awareness through numerous assessments, most recently the National Pediatric Readiness Project, which showed numerous gaps in the ability of our acute care facilities to care for the pediatric population. Numerous states have moved forward because of those known gaps to start to recognize facilities that are in fact able to manage critical illness and injury in children. There are a number of states that have various programs, some as long-standing as 30 years, others that are much more recent, but many states are starting to develop recognition programs in order to not only help to identify those hospitals that may be better able to care for pediatric patients, but also to identify the resources that are available in a particular region. Certainly the state of Texas is diverse and large, and one size will likely not fit all. And at this point, we're simply trying to increase awareness of the results of the National Pediatric Readiness Project, and specifically the data related to Texas, so that we can start to develop a discussion as to how this might look in the state of Texas, and if this is something that we'd like to do in the near future.
Dr. Remick, could you comment on the ultimate goal of the recognition program, and in the states that have embarked on this, how has that affected outcomes?
Sure. So there are numerous states that have started to look at outcomes. Illinois is probably the most well-known of those. Illinois has a voluntary process where approximately 60% of the facilities in the state have voluntarily submitted to on-site assessments to be able to self-categorize or self-recognize as a pediatric-ready facility. In that state, they've noticed significant decreases in mortality rates that have exceeded national trends in mortality rates over the last decade. There have also been some studies in the state of California looking at emergency departments approved for pediatrics, and in those facilities, they've noticed that they are much more compliant with national guidelines for pediatric readiness by as much as 30 percentage points greater. At this point, there's still a lot that needs to be done looking specifically at clinical outcomes, but there's enough there to suggest that if you're not ready, you're not going to be able to care for these critically ill or injured children. In this state, the goal really, as I somewhat alluded to, is to establish a system to recognize those facilities that are ready to care for pediatric patients, to increase awareness, to guidelines for pediatric-ready facilities, and hopefully to identify what resources are available in various regions and help to identify gaps.
So, thank you. So this committee has, in a previous iteration, some 9-10 years ago, embarked on a similar project, but without the data and the best practices that had existed at the time that now have demonstrated the improvement in mortality and improvement in both process and outcome metrics for children. So I think it's a very different setting, and we have learned much from other states where mortality has improved. So we would remain engaged in that as a line item in every one of our GETAC meetings for this subcommittee. So if there are documents that we can review and offer our feedback formally that we can post online, we would love to have those so that we can continue this discussion so that the public will be aware of what the elements are as they evolve.
Wonderful. Thank you so much.
I have a question.
Yes.
Is there any, we all believe on going through that process, we've all practiced in pediatric centers, but is there any tangible incentives for non-academic institutions or smaller, programs that take care of children in order to actually go and pursue that recognition?
Yeah, so a great example may be what they have done in the state of Arizona, where they've worked with the Arizona chapter of the American Academy of Pediatrics to do on-site assessments. And facilities actually buy in. They pay a membership fee that's pretty nominal, less than $200 to become a member of. It's through their neonatal trust program. And hospitals have actually paid in to be able to have someone come and assess their facility for recognition, and then they're able to display that they are a pediatric recognized facility. So it certainly could have some implications there.
Thank you.
Well, and I think to your point, there's also data to the opposite, that there's some very well-done studies demonstrating that in trauma facilities that are pediatric ready in the state of California versus those that weren't, for those that weren't, outcomes were definitely much poorer. So and even within the community, so not children's hospital based.
Exactly.
Mm-hmm.
So I think that gives good evidence to the value of improving quality in any facility, regardless of whether you're a pediatric hospital or a community-based hospital.
Right, and if I can just touch on that briefly, through the National Pediatric Readiness Project that was just completed, we know that 83% of children are seen in general emergency departments, so not in pediatric emergency departments and not in children's hospitals. So that's really where the biggest focus lies. And in addition to that, just really briefly, we saw in California that even being a level 1 or level 2 trauma center does not actually make a difference in readiness unless you have a verification process or some kind of recognition process in place.
That is exactly why I ask you, because we know that most of the children are seen in places that are, not tertiary care centers for pediatrics, especially in the state of Texas. Mm-hmm. Is the same thing. Mm-hmm. Thank you.
Thank you.
Great. So that brings us to agenda item number 6, update on pediatric transfer guidelines, interfacility transport. We don't have a draft for public review. We will be posting the draft after the discussion for this series of meetings.
Right.
We were hoping to go through some domains that have been discussed and understand controversial issues and/or issues of perhaps the highest yield.
Well, what I've given all of you is the draft that has been approved by the work team that was asked to draft this. And so if you guys will look it over and get your feedback to me, then I will ask Dr. Macias to put it on the agenda for us for November and hopefully be able to get it out to the other subcommittees and get it on their agenda as well. So this actually has not been revised a whole lot from what it was originally after Dr. Remick and I drafted it. It's very much like the Washington State transfer guideline with some specific Texas issues, and we tweaked the criteria a little bit to focus on abuse where it was lacking in the criteria. We also tweaked a little bit the deteriorating neurological status, so we defined that as equal to or less than a GCS of 14. So just read this over, see if you see any gaps, and please make those suggestions. I will send this out to you all electronically so you can do track changes on it if you want and get it back to me. And then hopefully we'll be able to finalize a draft amongst us and have it on the agenda for approval in November.
Okay. Do you just want to walk us through the key categories of, or domains of discussion so that we can share that with our audience members?
Okay. So the introduction just talks a little bit about why it's important to have a transfer guideline and how it facilitates the interfacility transfer of patients when you don't have to think about where you're going to send that patient at the time you have them in your emergency department. And then the second page is titled Consideration for Pediatric Consultation and Transfer for Trauma and Critical Illness. This is a transfer guideline that covers both medical patients and trauma patients. We know that there are a lot of hospitals in the state that already have a transfer agreement in place for trauma patients, but not so much for medical patients, and this would cover both. And then the next section is on consideration for pediatric trauma transfers. There's the physiologic criteria that should trigger a transfer, anatomic criteria, and then other criteria. And this is where I was saying we had put some specific child maltreatment criteria in because we feel like those patients are probably best cared for in a facility where there is a child abuse team. If you have access to that. And then the next section is on burns, what burn patients should be transferred, and it's basically the ABA criteria with item number 10 highlighted where it specifically talks about burns in children. And then other criteria for transfer, we talk a little bit about patients that require intensive care units, close observation, kids that would benefit from consultation with or transfer to a pediatric trauma center or a pediatric intensive care unit, and then children with injury suspicious of maltreatment. And then on the next page, consideration for pediatric non-trauma transfers. This is physiologic criteria from a medical condition standpoint, and then other criteria. And then on the next page, we talk a little bit about transport team and method of transport. There is a, under method, there is a section out of the Washington state guideline that we need to replace with our own Texas statute, or at least rules. And over, you'll see in the comment box, is all of the rules that we might pick from or just reference in our agreement or in our guideline that talks about the things that would influence the makeup of a transport team. There's information about the equipment, communication, and then obviously and importantly back transfers so patients go back to their home. And then the method of transport is on the next page. This pretty much follows the NHTSA guidelines for transport of children in ambulances. So that's pretty standard, well-referenced, and evidence-based. And then the transport team configuration, patient factors for BLS, ALS, pediatric-specific transport teams, and then when you're highly encouraged to use a pediatric transport team. And then lastly, we would like to have all of the contact information and maybe even a map of all the pediatric hospitals and and hospitals with pediatric capabilities in the state of Texas. So there's a start to a list of those designated pediatric trauma centers on the last page, and I got those off of the chat website. So
Great.
Any corrections or anything we can make to that.
Thank you. So two things that we'd like to address. One of them is the process of developing this. So can you tell us which other subcommittees have participated in your development group?
None of the other subcommittees. We had a subcommittee of our subcommittee, a sub of the sub, And Julie was in on that. She helped us with the transport aspect. Deb Boudreau from Cook Children's also. Dr. Remick, who has been involved with development of transfer guidelines. We had Justin from Amarillo area, Sarah Safrant from the Valley area, which is one of the regional advisory councils that has a high volume of pediatric patients that does not have a children's hospital. So we wanted to get their perspective as well. And Dr. Mitch Morber from Abilene.
So good cross-section
Yeah.
across the state, plus
Yeah.
of different skill sets.
Yeah, and then once, I think, obviously, once we vet this through the other subcommittees of GETAC, then there'll be some other input as well from medical directors and those people, EMS.
Okay, and one last piece, as with any intended QA project, what is your, we've talked a little bit about this before, but just wanted to keep this in line. What is its intended use?
It's purely a voluntary document, so there's no plan to put this into, or try to put it into statute. It's just an opportunity for hospitals to adopt, or for regional EMS systems and hospitals to adopt these guidelines, to give them an idea when and which patients should be transferred, and to encourage the development of referral guidelines, referral patterns for rapid movement of critically ill or injured children to the right resources.
So I think maybe one of the things that we can add to our agenda for February is by that time we should have had feedback from the other committees, been able to take the document after public comment to our umbrella GTAC group for approval, and then in February discuss a dissemination and implementation strategy for how we can get the word that out there that it's here.
Yeah, great.
So Sally, all the constructive criticism or questions, go directly to you?
Yes, please.
Okay.
Can I ask a question quickly? Was there a consideration of putting in some of our radiologic suggestions within this document? We had some, because we're talking about transfer, so we spent some time developing guidelines for who to radiograph if you're going to transfer. It might have a role, since we're creating this document,
Right.
to incorporate a section on that.
We hadn't thought about that, but that's a good idea.
I think that's a great cut and paste
Yeah.
back to, and hyperlink back to that other document.
Mm-hmm.
Okay. Great. Any other comments? Audience member comments? All right. So that takes us, thank you, Sally, for some really hard work on that. That takes us to an update on our EMS Clinical Guidelines project. Sam, are you doing that for Dr. Shaw?
He wasn't able to be here today, so he apologizes. Basically, he wanted to give an update on the NASIMSO Model Clinical EMS Guidelines, which is the National Association of State EMS Officials with support from the National Highway Traffic Safety Administration. Will be releasing those Model Clinical EMS Guidelines in October of 2014. The guidelines cover approximately 40 different clinical situations and provide guidance for EMS medical directors to create protocols for their EMS systems. The guideline work group had representatives from several EMS stakeholder organizations from across the country, including several state EMS medical directors. The guidelines are mainly consensus-based, but in situations when there was an existing guideline created by the National Pre-Hospital Evidence-Based Guideline Model Process, endorsed by the Federal Interagency Committee on EMS, or FICOMS, and the National EMS Advisory Council, or NIMSAC, the content of those evidence-based guidelines was included. The evidence-based guidelines that are in the resource include airway management, allergic reactions, asthma, bronchiolitis, croup, pain management, seizure, shock, including the control of external hemorrhage, and spinal care. And from a pediatric perspective, the American Academy of Pediatrics had 2 representatives on this work group. The first was Dr. Brian Moore, who is a pediatric emergency medicine physician and New Mexico's state EMS medical director. And the second was Dr. Shaw, who, as you know, is the program director for the EMS for Children State Partnership here in Texas. In addition, there were 5 additional pediatric emergency medicine physicians who helped review each of the guidelines to integrate pediatric needs into the document. One of those is actually Dr. Remick, who was just speaking, who is also on the Medical Directors Committee of GETAC. The other update that he wanted to give was on the Pegasus project that he is the principal investigator on. Pegasus is an acronym that Dr. Shaw came up with that stands for the Pediatric Evidence-Based Guidelines Assessment of System-Wide Utilization in States. Yeah, Dr. Shaw comes up with some acronyms now. Anyway. But the Guideline Development Committee used the FICOMS and NIMSAC endorsed pre-hospital evidence-based guideline model process to create the following 4 guidelines, which is airway management, allergic reactions, shock, and spinal care. So the Pegasus guidelines will be integrated into the NISIMSO model clinical EMS guidelines. And these have been created with a multidisciplinary committee of EMS medical directors, pediatric emergency medicine physicians, paramedics, and parent representatives from Texas and from New England. The guidelines will be implemented in the City of Houston Fire Department EMS in October of this year, and they will be implemented in the 6 New England states in the spring of 2015. Dr. Shaw will be giving a presentation about the content of these guidelines at the Texas EMS Conference on Monday, November 24th. And these guidelines are currently being written up for anticipated publication in July of 2015. So.
Thank you. I think it might be worth just taking a moment to talk about the purpose of guidelines. These aren't simply intended ever to be prescriptive, that the very direction of healthcare reform is about minimizing standardization, minimizing unwanted variation in clinical care practices for a couple of reasons. One, to get rid of unwanted waste in a system. And the second, to be able to look at the comparative effectiveness outcomes of different strategies to be able to do things. So while these are wonderful opportunities, and they are absolutely great opportunities to see a lot of this work emanating in Texas, it is clear that this is the future of healthcare. So it's wonderful to not only see this as part of pediatric practice, but as pediatric practice driven in this state. So
it is, and I would also like to add to that these are the very first evidence-based pediatric guidelines for EMS that have been developed in the country. So
great.
It's being done here in Texas, just letting you know.
Any questions for Sam that can get forwarded to Dr. Shaw?
I was going to say you can ask me, I probably won't know the answer. But.
Great.
All right,
thank you, Sam. Let's see. Next item, that took us through item number 7 and 8. So number 9, update on the State of Texas Emergency Assistance Registry. The specific question, Dr. Hartstein, was to address what are the pediatric issues related to that. Do we have our slide available?
Thanks a lot, Charles. So just an update on the STEER program and a little bit of background. This slide I received from Dee Dee Powell, who's the state coordinator for this effort, and also from in communication with Sharon Knowles, or Nichols. At any rate, I don't believe either of them is in the audience, so I'll give a little bit of a background for those who are unfamiliar with this. In 2012, a statewide system that was, I think, nicknamed TAR, or the Transportation Assistance Registry, I believe are what it stood for, which was an attempt to alert local municipalities to individuals in the area who would need assistance with transportation in the case of an evacuation. In 2012, that program migrated over to the STEER program. A few differences in the two programs. The biggest difference is that the current STEER program is a yearly registration that the individual who self-identifies as needing additional assistance in the case of evacuation must update their own registration every year. There is archived information that's kept, but this was because and as such the program is not quite as widely implemented. There are about, I guess, 130,000 individuals in the TAR program, and there's but about a quarter of them or more were out of date, so it wasn't a very useful registry. If something actually happened, it wasn't clear who was still in the location they said they were and the assistance they needed, so it wasn't as useful a tool. This tool now has, as you can see, the numbers, approximately 25,000 registrants, 4% or so of which are children or minors. So not quite as wide a reach, but more accurate information. It's mostly targeting transportation and electricity needs for ventilators, et cetera, and not as much. You can see there's another slide attached here. So there are some, is this the second slide? Oh, sorry. So there's a little bit of some medical questions, but not a lot of detailed information regarding one's medical condition or required medications, but it does alert the system or the EMS system if folks need additional help, oxygen, et cetera. How this has been deployed. Currently, the city of Houston has used it a few times, I'm told, and some of the coastal regions. It helps the EMS teams understand where they might why they might set up pods or distribution areas to assist specific individuals, focusing on nursing homes, often focusing on locations where you have a concentration of elderly individuals. There isn't necessarily a strategy for it, whereas there's mandatory information. There's a state law that requires information to be, or this registration to be offered at assisted living facilities, et cetera. There really isn't such a mandate for pediatric populations. So I'm not sure how, I mean, you can see by the numbers that it's not necessarily widely deployed across the pediatric population. I'm not, so that.
Go back. Yeah, back.
So it might be something to consider, what ways or how might this be better communicated to pediatric patient populations with high-risk conditions that require assisted transportation modalities in the case of an evacuation. I don't necessarily have an answer, but I pose it to the group.
Yeah, well, it's an interesting question with considering the overlay of the number of children with complex care needs in the state, and clearly that number far exceeds the 1,130 registrants described there as a minor. So certainly a gap.
Right. So I think we know that we can see that, and the idea that it has to be frequently updated. It may pose a burden to the individual caregiver, and it might be something to consider having a institutional approach, maybe based in pediatric hospitals or areas where we know that there's a concentration of children with special needs.
So as a quality improvement strategy, I can think of at least a couple of ways we can approach this for the committee. The first is clearly a discussion with our disaster committee partners. But the second is considering the dissemination approach, the institutional approach you described, the role of children's hospitals, the role of organizations like the Children's Hospital Association, to understand how to better link this, perhaps even linkage with emergency medical services for children. So I'm going to put this back on our November agenda with a charge back to this group and our absentee members to consider QI dissemination and implementation strategies and take your feedback for what that might look like in order to enhance those 1130 numbers. In the meantime, is there a way we can get a sense of the number, a more accurate number of the number of complex care kids? And I don't know if Children's Hospital Association would have that type of number, or if that could be sort of abstracted and estimated based on complex care clinics.
So maybe we can talk offline, and I can do some research if you have some leads. One comment I'll make about the program is that they haven't so much that the individuals who, like Dee Dee, who's spearheading the program, when I speak with her, she isn't so much trying to push on municipalities what they need to do more, or try to aggressively advertise a resource that may not be there. So I think that there's a balance between, I think we also have to partner with the STEER group, or maybe with RACs or somebody to say, what is your area capable of doing? Or how can we communicate to you that we've facilitated communication to add all these kids to the registry, and are you capable of actually doing something to evacuate them should, the balloon go up or whatever, the hurricane come in, et cetera.
Dr. Macias, one of the things that we have just implemented in the city of Fort Worth is a program called SNAP, Special Needs Assistance Program. It's through the Fort Worth Fire Department. And we came up with a flyer to hand out to our patients that says, if you have a special needs child in your home, go to this website and register. And then when the fire department gets a call from that address, it will automatically pull up information about the technologies that are in use in that home. And it's a nationwide program. It's just a matter of the individual fire department dedicating the resources to, get a computer for it and someone to track it and stuff like that. So it's a pretty cool program.
Well, that might actually be worth demonstrating. Do you think you could get a live link for our next meeting?
Yeah,
we can set that up here.
I'll try to do that. Our the injury prevention coordinator at Cooks has been very integrally involved with the fire department getting that up and running.
Sam, you had a comment?
Yeah, I was just going to let you know that as far as gathering more information on where you might be able to find these children, you could consult with the Texas Parent-to-Parent organization, as well as DSHS also has a medical home work group committee that meets, and they may possibly have more information on where these kids live at.
Great.
Just to let you know.
Thank you. Those are great leads. So your follow-up on those leads and a demonstration on the SNAP program.
Yeah.
And then some consideration.
And we'll be right
for
there in
additional-
Fort Worth in November, so
perfect.
maybe we can look at it.
You'll be at home. All right. Any comments on that? All right. So we move on to item number 10, quality performance metrics for the improvement of care of children in emergent and urgent care settings, including the use of system performance improvement metrics linked to pediatrics and integration of EMS performance metrics. So I can speak to this, Sally, and if you want to add to this, since you're on the same COPEM work group. So the American Academy of Pediatrics houses two pediatric emergency medicine organizations. One of them is the Section on Emergency Medicine. It's the largest professional society that umbrellas pediatric emergency medicine physicians that are active in the Academy's activities, and that's about 1,300 members. On the advocacy and legislative side is the Committee for Pediatric Emergency Medicine. They are integral in the development of policy statements for the Academy, as well as technical reports. So both Sally and I sit on the COPEM committee for the Academy. And we have nationally taken on this project along with a partner at Cincinnati Children's, and who's our fourth? Kansas City. Evie and Laura Morris. Yeah. So we will be developing a position paper on behalf of the Academy to determine what quality performance metrics are there for are currently existing what has been tested to know what is reliable and valid for measuring systems of care's performance for pediatric emergency medicine, whether that is in a pre-hospital basis in an emergency department's setting, and linking that to outcomes of care in order to be able to develop a position for where we should be creating national agendas and national legislation. So we will continue to bring updates on that to this group. We would love to hear feedback as we evolve that. That report has been approved for development over 14 months, which is not a lot of time. So we'll go fairly rapid with that. So just be on the lookout for that, and anything that we post as a draft, we'd love to have public comment on that, since these measurement systems will exist with or without us. Better it exists driven by us than by organizations unfamiliar with the state of pediatric emergency care. All right, Jorge, trauma registry update.
They'll be meeting tomorrow. I can send you a report about that. I actually, unfortunately, didn't make it in the last couple of phone calls, But do you have anything else, to add? For
No, I think we'll have a more comprehensive idea of what's going on tomorrow.
All right, so we have an agenda item related to the GETAC strategic plan. There are documents, I think, with every subcommittee that are posted for public review on the strategic plan, but we disseminated two in particular. One that I wanted to bring to your attention. One is the 2002 strategic plan. That document is entitled "A Strategic Plan for the Texas EMS Trauma System." And it goes through various domains. There is a work group of GETAC committee representation or subcommittee representation that we clearly have a seat on as well, that are looking at categories and topics for potential inclusion. The long-term plan, as it currently stands, is providing input on the plan development during this GETAC committee agenda, developing a plan based upon the agreed-upon strategic framework in November of, I think this should read 2014, obtaining public comment on the plan February of 2015, initial, and then May 2015 final, council approval August of 2015. So within those documents that have been posted, which include the categories for potential strategic plan discussion and the strategic plan crosswalk, if you take all of those elements, I just wanted to hit upon where the current range of discussion sits, and that scope is integrated delivery services, which was on the 2002 plan, clinical care, which was on the 2002 plan. In fact, let me just go through the list of what was on the 2002 plan that's on this plan, on this trajectory or proposed plan as well. Communications and systems, legislation and regulation, medical oversight, prevention, research, and funding or system finance. What was on the 2002 plan as a domain that does not exist on, or at least not as a separate domain, on the current strategy that's in discussion is public access, public education, human resources, education systems, information systems, and evaluation. What does exist on the current strategy domain discussion that was not on the 2002 plan, so you're hopefully getting a walkthrough on this: rehabilitation, special populations, community outreach, equipment resources, geographical challenges, performance improvement, patient safety, preparedness, professional education, sustainable system funding, which I think really fits into the system finance, reimbursement payment, system access, system leadership, workforce, and health information. I think the one piece that sort of seems to be a burning platform is the evaluation component that we see referred to in the 2002 plan, that really is encompassed in a much more developed improvement science model 12 years later as quality improvement. and fits within the domains of performance improvement, patient safety. I think that 90% of what we've talked about really fits in that, and I see, at least from my crosswalk, it seems to me that a great percentage of our agenda is dedicated to performance improvement, patient safety, and the betterment of outcomes. It seems like most of the projects we have talked about have been in that domain. So as we look at evaluation and development of the new strategic plan, I would recommend to this group that we very heavily focus on that piece of performance improvement as it relates to the pediatric population. And in any of those models, that requires an attention to minimizing unwanted variation, standardizing care, and evidence-based practice as one domain. The second is how we use informatics, data analytics, and understanding how we evaluate systems. And the third is how we conduct care process improvement and roll out implementation and dissemination of best practices. So within those conceptual models, as you review those plans and give your feedback, we'll have an opportunity in November. What I wanted to discuss today, given the timeline benchmarks that you've heard, we would take a similar stance as we did with our previous review of proposed just drew a blank there, rules revisions, to have a 3 to 4 hour session separately so that we can really drill down into an existing document, bringing our ideas and understanding where we can integrate that. So the most reasonable times to do that, given the construct of the feedback for this timeline that has been agreed upon for the strategic plan framework development, seems to be somewhere around November and December. Much of what we do is predicated on looking at the special population of children and understanding that, so we have to have enough build from the other committees to understand these implications. So starting too early won't give us enough information. Starting too late will be too late to feedback significant implications. If you're in agreement, it seems that the additional meeting should occur sometime in November or December. Does that sound reasonable? Is the rationale? Okay. We would need to post that meeting for the ability for our public interaction for anybody that would need to go there. So we'd have to define that date by September. Is that okay? To get that posted. So why don't I will send out some dates, potential dates in November and December to the group. Once we hone in on that date, I'll forward that date by mid-September. So that means we must confirm that date by mid-September to be able to get that posted. I'll send back what we talked about today, minutes plus another copy of the 2002 strategic plan and the current document, which for lack of a better name, we'll just call an overview and proposed changes and timeline. With that, any questions on that process?
Will that be an in-person meeting, a dialogue meeting?
That would be an in-person meeting, so thank you for reminding me of that. So I don't think that can be a dial-in meeting, correct?
I'm not sure.
Okay. We'll check on the compliance issues related to that. I know we're fairly strict, but I'm no expert at what we can and can't do with public presence. So, with that being said, I think that takes us through all our agenda items. I'm just going to go through and review our charges as defined today. And that looks like the following. So we've all got our liaison reports that we will follow up with. My charge to follow up with the child fatality review team, identify that liaison, determine if that team has selected a new liaison. Jorge and Dr. Juarez will bring potential rules revisions to our February meeting for minimizing CT radiation in children. for our pediatric facility program. As a group, we will review any documents brought forth by Dr. Remick's subgroup and EMSC. We will post those so that we can also get public comment on that. I don't think we had anything outstanding for EMSC that we needed to review other than that. For our update on pediatric transfer guidelines, we will post that document for detailed review. Please use track changes for your edits and put comments off to the side so that we can understand what your thought process was with those edits. And we will have a document then to submit back to other subcommittees for the November meeting. Would that, Sally, be done in time for a November GETAC submission, or is that a February big GETAC submission for approval?
It seems to me like if we get it to the other subcommittees in November, hopefully they'll give us their feedback. We can maybe come up with a proposed document for final approval by the subcommittees in November, and then if we get final approval by those subcommittees, we could go ahead and put it on the GETAC agenda.
Okay. That might be a little bit challenging because our time slot is 10:30 on the first day, which means Saturday before only disaster will have met that day.
Okay.
So we may have to push to February,
Okay.
depending on the comments. So we'll get a placeholder. We'll present this to GTAC with a potential placeholder based on the scope of revisions. And if we can make the revisions in time to submit, then we'll do so. But if there's significant revisions, we may need to submit in February.
Do you think we could do our revisions electronically and then go ahead and put it on the other subcommittee agendas?
That was my thought.
Okay,
Yeah.
for
So if you could just give us
November.
a target of where that
Perfect.
needs to go. Okay.
Okay.
So potentially, we could have that to the GTAC committee. Then for EMS Clinical Guidelines Project, or Pegasus, nothing at this point other than a February agenda item to look at content. And then for STEER, Dr. Hartstein and Diana have some follow-up to identify current existing groups and scope of special needs, and a demonstration in the November meeting of the SNAP program. Quality metrics update is my charge to provide any updates and draft documents from the COPM committee from the Academy for a position paper. Trauma registry update in our next agenda item. GTAC strategic plan update. I'll send dates out, and we'll get feedback and a date locked in by September. Any additions to the charges? Have I forgotten anything? Anything else we need to do? All right. At this point, then, we will open this up for any items from the public. Anything that was not addressed within this meeting that anyone from the public would like to address. Sam?
Sorry.
We're going to have to get the seat up here.
Well, that would make it easier. Anyway, I just wanted to talk about something that Charles had mentioned earlier that the Education Committee is working on as far as mobile integrated healthcare or community paramedicine programs. Dr. Andrew Stevens, who is the medical director for Indianapolis, Indiana, has a targeted issues grant that he is working on. It's a mobile integrated healthcare for the Indianapolis Fire and EMS to decrease recidivism of pediatric asthma patients. He is supposed to be sending me some information on that. They're a long way off from publishing, but he's going to send me some information on that. I'd be happy to forward that on to you. Also, something that's going on here in Texas, just found out yesterday that Children's Medical Center in Dallas is actually working with the Dallas Fire Department on a similar program. Dallas already has their adult mobile integrated healthcare, and they're going to start working with Children's there in Dallas as far as working with kids and asthma there as well. So,
Well, I think that with so many best practices out there and such potential for paramedicine, it seems worthwhile to explore this as a separate line item on our agenda in the November meeting. Charles, would you like to work with somebody to take that on, reach out to Sam for some of this preliminary data? Is there somebody else in the group who would like to partner with Charles to address this?
Somebody's thinking
Just one update, I'm Lori from Children's in Dallas. It's also our Plano campus, so we have 2 EMS agencies that's working on this. Dallas Fire and Rescue is working on it, as well as Plano EMS with our Plano campus. So there's 2 actively pursuing their programs, and both focuses are asthma.
Will you be at the GETAC meeting in Fort Worth in November?
Yes.
Would the 2 of you like to present an update and show us a sort of a best practice for the type of program you've presented? We can
Yeah,
carve
let me
out
also
about
talk
10
with
minutes.
Chief Seals from Dallas, and also everyone in Plano, and I'd want to include them as well.
Okay, great, perfect.
Okay.
All right. Any other comments?
Dr. Drucker with the Injury Epidemiology and Surveillance Branch. Just wanted to bring the attention to the Pediatric Committee that on the DSHS website there is an updated pediatric report. It's a lot more involved than the pediatric report that's been presented previously. It includes data that's submitted to the registry from the EMS runs, from hospitalizations and submersions. This report was presented yesterday at the EMS for Children's Advisory Committee. We had a lengthy discussion about the data, and so we're always looking for feedback from stakeholders on how we can improve the report and how to disseminate it to benefit Texas as a whole.
Is this similar to the report that we viewed off the trauma registry 2 meetings ago, I believe?
That was the first
Iteration.
report that Dr. Denson put together and presented. This is a more expansive report.
Can we put a, can we get a glimpse of what that looks like in our November meeting? And Diana, as our injury prevention liaison, would you mind shepherding that discussion?
Sure.
Great. Let's assign 5-ish to 10-ish minutes with hopefully a display on PowerPoint.
Okay.
Perfect. Thank you. Any other comments? All right. Well, thank you so much. This meeting is now adjourned.